Tēnā koutou katoa. Hope everyone is enjoying the school holidays, and I'm sure you'll be pleased to know there's only 80 days left until Christmas. With all that's happening at the moment, though, it's a good time and opportunity to remind everyone to be kind. And this evening, Mobile Health has been very kind in arranging tonight's speaker, Dr. Faeez. Dr. Faeez undertook his base training in India before completing his interventional fellowship training at Waikato, after which he completed further structural training at St. Michael's Hospital in Toronto. His main focus of interest is in aortic, mitral, and tricuspid disease, percutaneous intervention. After finishing his structural fellowship, he joined Waikato Hospital in December 2020 as a specialist interventional cardiologist. And lucky for us tonight, he will present a webinar on aortic stenosis, prevalent, progressive, and deadly. Sounds very intriguing. Thank you. I'll now hand you over.
Thank you, Kathy. Thank you. It really is a pleasure to talk on this relevant topic. And a big thanks to Kathy, Emma, Pauline, the entire team from Edwards to organize this webinar. So my aim today is to talk about a very relevant topic, which is aortic stenosis, which we see so commonly in the hospital with so many people suffering from it. My basic aim is to take you through, no disclosures in this talk, is to talk about the general prevalence of aortic stenosis, the prognosis, how you diagnose it, what all treatment options are available, and I'll just briefly touch upon the updated guidelines, which was just released this year, as well as a few points last year, and something controversial, which is about the lifetime management of aortic stenosis, because there are so many options that we face right now. So before I actually go into the presentation per se, I'm just going to set out a couple of questions. So just 4 questions to get you guys thinking, and just give me, you can always type out the answer in the chat box, and we will go through the answers in the discussion, and we will touch upon it at the end as well. All right, so here we go. The first question is the prevalence of aortic stenosis in people over 75 years of age. Is it 1 in 4, 1 in 8, 1 in 16, 1 in 20? Just take a guess. Do you see anything, Kathy, in the
yeah,
chat?
So at the moment, you've got a few in the A category, 1 in 4, and we've got a couple in the 1 in 8.
Oh, perfect. Always a 50% chance of being right now. All right, we'll come back to this in the end. Next question. So which of the following has the worst prognosis? Is it metastatic breast cancer, metastatic lung cancer, metastatic colorectal cancer, severe aortic stenosis, or metastatic ovarian cancer? This has to be pretty obvious. I have nothing to do with any of the other topics, so this has to be pretty obvious.
And so with this one, the strongest seem to be coming through as B and D.
B and D, is it? All right, good. A good range over there then. All right, so a clinical question. What characteristic of the aortic stenosis murmur helps determine the clinical severity of stenosis? When you auscultate, what characteristic do you look for? Is the duration of the murmur? Is it the loudness or intensity of the murmur? Is it the location of the precordium? All of the above or none of the above?
And with that one, your answers seem to be mostly A and D, and then some with an E.
Oh, perfect. That's good. Good range. All right, so the final question. So which of the following regarding transcatheter aortic valve replacement is correct? Is it reserved only for the elderly or high-risk patients with severe aortic stenosis? B, it may be considered for patients with severe aortic stenosis and bicuspid valves. C, the stroke risk with TAVI is higher than surgical aortic valve replacement. Or is it D, infective endocarditis prophylaxis is not needed after TAVI?
And with that one, you've got a few B's, B's, and A's. A little bit more mixed on that one.
That's great. So my talk is relevant today. Right? All right. So what essentially is aortic stenosis? So the aortic valve is the central outflow valve of the left ventricle. It opens and closes with each heartbeat. The normal valve area is about 3 to 4 centimeters square. That's a normal native valve. But commonly what happens is when the valve area reduces to less than 1/4 of its normal area, that is less than 1 centimeter square, that's when you call it severe aortic stenosis. And that's usually when symptoms start propping up. So this is the normal tri-leaflet aortic valve. There are 3 cusps, 3 leaflets. And the most common cause of aortic stenosis that we see, especially in New Zealand over here, is calcific stenosis of the aortic valve. There's a lot of calcium deposits that you see in panel D over here. And this usually happens with old age and other risk factors, which we will come to. Another very important cause of aortic stenosis that we see is a bicuspid valve. So in the normal valve is 3 leaflets. In a bicuspid valve, the 2 of the leaflets are congenitally fused. In this case, it's these 2 leaflets over here at the bottom, and you can see the central raphe. The issue with the bicuspid valve is, one, it's genetic. So 2% of the cases are inherited. There's a genetic predisposition to it. And these valves degenerate at an earlier age than the calcific tri-leaflet valves. The patients with bicuspid aortic valve usually present in their 50s, 60s, or 70s, whereas the tri-leaflet calcific valves are usually in the 70s and 80s and above. Another common cause of aortic stenosis that we see, surprisingly, in New Zealand over here is rheumatic fever and rheumatic heart disease, where you can see that the commissures are all fused and you have a central opening. And that's one of the important causes of aortic stenosis in patients with rheumatic fever, usually in the younger age group. So essentially what happens is when the valve is stenosed, the left ventricle has to pump a lot more to get the same amount of blood across. And when patients exert themselves, the heart cannot keep up with the metabolic demand, and they go on to develop symptoms. The commonest cause, as I mentioned, is calcific stenosis. That's a normal valve. Over a period of time, there's calcium deposits. And you have mild stenosis that progresses to moderate and eventually becomes severe stenosis. There are certain factors that increase the risk of developing aortic stenosis. Old age, that's something nobody can control. Cardiovascular risk factors, hypertension, diabetes, smoking, other comorbidities like chronic kidney disease, coronary artery disease. It's essentially the same risk factors that are involved in coronary artery disease when you have atherosclerotic plaque buildup. So why certain patients have a predilection to involve the valve per se and may not involve the arteries or other areas, the reason is not exactly known, but it's essentially these risk factors that contribute to an atherosclerotic thickening and eventual calcification of the valve. So the first question, what is the prevalence of aortic stenosis? It's estimated 1 in 8 people over 75 years of age have aortic stenosis. That's a pretty big number. It's roughly 12 to 12.5% of patients over 75 have some form of stenosis. It may be mild, moderate, severe, but at least 1/3 have severe aortic stenosis, 1/3 of the 12.5%. So just to put things into perspective, if you are seeing roughly 20 patients per week over 75 years of age, you would roughly, in a year, you would see about 1,000 patients, and of them, 12.5% would have some form of aortic stenosis. That's 129 patients would have aortic stenosis. Roughly 1/3 or 35 would have severe aortic stenosis, and roughly half of them, or 17 patients, would not survive past 2 years if left untreated. If you're sitting in a bigger practice, we see, say, 60 patients over 75 per week, you'd roughly see around 3,000 patients a year, and that amounts to about 387 or 12.5% of patients who have some form of aortic stenosis, 1/3 of which have at least moderate to severe, and if not treated, 50% or 53 of them would die if left untreated with one way or the other. So it's very common. And in clinic, if you've seen, say, 10 patients, I'm certain one of them would have some form of aortic stenosis. So it causes debilitating symptoms. The classical symptoms that are described are exertional dyspnea, exertional chest pain or angina, and pre-syncope or syncope. Unexplained fatigue has also been added on recently as one of the characteristic symptoms, but you have to obviously rule out other causes as well. But it's so common, it's so vague that you don't attribute it to a particular heart condition. The thing that we really see is that aortic stenosis is a very insidious disease. People present, when we see patients in clinic, they often say, "Oh, I'm just getting old. I'm just slowing down. I'm just unfit." So that's how they. What happens is they develop symptoms. It starts slowly. It's insidious in onset, and people usually tend to adjust their lives around their symptoms. They start slowing down. They stop going for walks. They stop gardening. And when you ask them why, I'm just slowing, they just say, "I'm just getting old. I'm just unfit." It's extremely insidious, and that's the dangerous part of aortic stenosis, because once they really start becoming symptomatic, as you'll see in the next slide, things go downhill very fast. So one of the things that we often do in clinics is we ask them, "Are you able to keep up with the rest of your peers? Are you able to keep up with your partner?" And because both of them essentially age together, and if one lags behind the other, it's a subtle clue that tells you that something's not right. So as I said, it's a very insidious disease. There's a long latent period before symptoms actually come out, partly because the heart compensates through various mechanisms to keep the blood flow going. But it's only once the heart starts struggling to keep up the output that symptoms really start. And the classical symptoms are angina, syncope, dyspnea, the characteristic triad. And it's estimated once symptoms start, the average survival, depending on the type of symptom, is about approximately 5 years for angina, 3 years for syncope, and 2 years for heart failure. That's a very old study from the 1950s, back when Braunwald was at his peak. But in essence, once you have symptoms, 50% of patients will not see beyond 2 years. That's the rough estimate. So what is a prognosis? This answers our second or third question. This is the survival of severe aortic stenosis, 5-year survival of severe aortic stenosis compared to metastatic lung, colorectal, breast, ovarian, prostate cancers. All the most common cancers of New Zealand, severe aortic stenosis trumps them all. So you hear about different malignancy days like colorectal cancer day, lung cancer day, prostate cancer day. There's no severe aortic stenosis day, I can tell you that. And it's possibly because we as cardiologists and the medical field have done a poor job in highlighting how bad it can be. So I guess this is one step forward towards letting the public know that this is not a benign disease at all. And it's just because the symptoms are so insidious in onset, it is underdiagnosed and undertreated. And it's in multiple studies from the 90s and early 2000s have shown that nearly 40% of patients are not treated. And this can be due to multiple factors. Either they are not picked up, they die before they come in, or they're too sick when they come in, they've really missed the bus. So how do you diagnose aortic stenosis? Well, there are multiple modalities to diagnose aortic stenosis. It all really starts from a clinical examination at the primary care physician's office, listening to their symptoms. Any patient above 65 years of age, when you speak to them and they have the symptoms of shortness of breath or fatigue, dyspnea, angina, whatever it is, a clinical examination is usually what follows. Examination of the pulse, the blood pressure, examination of the precordium, basic blood examination, blood test, which I'll come to, looking at the ECG. In most cases, you'll be able to make a provisional diagnosis of some form of aortic stenosis just from a clinical examination. And then, of course, comes the imaging part, echo, and so on and so forth. There are other advanced tests to diagnose aortic stenosis, like CT and cardiac cath, and so on and so forth. but those are only reserved for exceptional cases where there's an uncertainty in diagnosis. So in most cases, it can be made with a good clinical examination followed by imaging. So when it comes to examination, the first thing that you do is feel the pulse. Don't just count the pulse, feel it, because that will give you a good clue as to what the underlying disease might be. The normal pulse has got a brisk upstroke and a brisk downstroke when you feel it. But when there is aortic stenosis, the left ventricle has to pump against a fixed obstruction. So the same amount of blood is pumped across initially over a longer period of time. So you'll have a slow rising and a late peaking pulse followed by a slow drop off. So it's called a lazy pulse, or in the Latin terms, pulsus parvus et etaris, where you have a delayed peak. It's a low volume pulse and it peaks late. That's a very important sign of aortic stenosis and tells you about the severity as well. Now, one of the main important confounding factors is in old age, which most patients with severe aortic stenosis are old. There you might have some atherosclerotic thickening of the radial arteries or arteriolosclerosis, in which case you may not see the sign. But if you do see it, then think of aortic stenosis. The next thing is the blood pressure. When you measure the blood pressure, if you see a low systolic pressure with a high diastolic, or what you call systolic decapitation, it gives you a clue that there's some form of left ventricular outflow tract obstruction. Auscultation is extremely important. This is where you pick up the characteristic murmur of aortic stenosis. The classical murmur is described as a harsh ejection systolic murmur, a diamond-shaped murmur, or a crescendo-decrescendo murmur. There are different areas of the heart that you need to auscultate, which I'll show you in a second. There you go. So the right second intercostal space is called the aortic area. That's where you hear the aortic stenosis murmurs or any murmur originating from the aortic valve quite well. The left second interspace is called the pulmonic area. The lower sternal area is the tricuspid area, and the apex is the mitral area. Now, there's another area over here called the second aortic area. It's called Erb's point. Some patients with aortic stenosis, you may hear the murmur better at this point rather than the classically described murmur in the aortic area. So as I said, the classic murmur is an ejection systolic murmur, or a diamond-shaped or a crescendo-decrescendo murmur. It's best heard in the base of the heart, and it's usually conducted into the carotid arteries. Now, you can determine the severity of the stenosis by listening to when the murmur peaks. If it peaks early, it's usually a mild stenosis. If it peaks late, it tells you about a severe stenosis. So how do you know if it's early, mid, or late? By listening to a murmur. So the clue is you can palpate the carotid pulse and listen to the murmur at the same time. A benign murmur, a flow murmur, where you have a similar ejection systolic murmur, it usually peaks when the carotid pulse hits. That's an early peaking murmur. If you feel a distinct gap between the carotid pulse and the late peakingness of the murmur, that tells you it's late peaking, and that probably is a significant stenosis. It tells you about the severity of stenosis. So a late peaking murmur tells you that the stenosis is severe. And that's one of the answers to the initial questions. Obviously, it conducts to the carotids as well. It's important to listen to the second heart sound as well. That gives you a clue. Normally, if you in a patient, especially in slightly younger patients, if you listen to the second sound in the pulmonic area, there's two components, an A2 and a P2. A2 comes from the aortic valve, P2 from the pulmonic valve. In severe aortic stenosis, you can have a reverse splitting where you can have P2 first followed by A2. To clinically pick it up, what do? Just listen to the second heart sound in the pulmonic area. In inspiration, if you hear a splitting of the sound, that's a normal split. And in expiration, you hear a single sound. But in severe aortic stenosis, it's just the opposite. In inspiration, in inspiration, you might hear a single sound, and in expiration, you hear a double sound. That's just the opposite of the normal. That tells you there might be significant aortic stenosis. But most of these valves are so heavily calcified that you won't hear an A2 component. So people don't emphasize on it too much. It's more the delayed peaking of the murmur that really gives you a clue. So if you can hear, I'm just going to give you a recording of the murmur that I did. That's the aortic area. You can hear the breath sounds in the background, and you can hear the ejection systolic murmur. And often it's conducted to the carotids. And that you can distinguish it from a flow murmur, because flow murmurs don't go to the carotids. That's the pulmonic area. That's the tricuspid area. You may hear a faint murmur at this point. And that's the mitral area. Sometimes the murmur of aortic stenosis is quite loud and can be heard all over the precordium. And you may even hear the murmur. You may even hear the murmur conducted to the apex as well, which is a sign called Caravello's sign. The next thing that you often look into is the ECG. So a 12-lead ECG, the most important sign that you look for is left ventricular hypertrophy. There are multiple criteria that you can follow, but what you see over here is a pressure overloading pattern, where you have tall R waves in V5, V6, with tall S waves in V1, V2. And the sum of the S waves plus the sum of the R waves, if it's more than 35, tells you there's significant left ventricular hypertrophy. It's not always reliable. You can have patients who are quite built quite well. And in those cases, if you have thick chest walls, you may not see these signs. So it's not very sensitive, so to speak. So once a clinical diagnosis is made, to confirm the diagnosis, more than 95% of cases are confirmed by a transthoracic echocardiogram. An echo is essentially done through the chest with an ultrasound probe, and you can look at the morphology of the valve. You can diagnose the severity of stenosis. You can look at the function of the left ventricle, function of the right ventricle, other chambers present in other valve diseases. It gives you a comprehensive assessment of cardiac function. So take these examples. You can look at the valve morphology. So this picture on top is a bicuspid valve. You can see two leaflets. One leaflet is calcified and fused. The one on the bottom over here is a unicuspid valve. It's extremely rare. It looks like a diaphragm with a central fish mouth-like opening. And these patients usually present in the first 20 years of life, invariably. It's not a disease of old age. And this picture over here, you can see a quadricuspid valve. You have four leaflets over here. Quadricuspid valves, by rule, they are leaky. They never present with stenosis. They are a leaky valve. So it's just the opposite spectrum of aortic stenosis. Then, of course, you can look at the left ventricle. You can see this muscle is quite thick. This is the entire structure of the left ventricle. This is the mitral valve. And the structure over here is the aortic valve. You can see it's calcified and slightly domy, probably a bicuspid valve. So you can look at how well the left ventricle is squeezing. In this case, it's squeezing pretty well. So you know the LV function is good. And you can interrogate the Doppler gradients across the valve over here. And that tells you the severity of stenosis. If it's above 40, it tells you it's severe stenosis. 20 to 40 is moderate, and less than 20 is mild aortic stenosis. So once you diagnose a patient with aortic stenosis, if you have a baseline echo, the guidelines tell you that you can follow that on a routine basis to look how the gradients are progressing or the LV function is doing over a period of time. So it's very useful to have an echo to confirm the diagnosis. So that being said, I will take this opportunity to say that every year or so, we organize a structural heart disease symposium. It was not done last year because of COVID. So this time around, we're planning to do it sometime in April or May of 2022, and we are planning echo session for GPs as point of care. So I'm putting it out there right now. You guys will receive posters and things later. Right. So as I said, aortic stenosis is a very insidious onset disease, but once they become symptomatic, that's a rapid downhill course, with nearly 50% of patients dying within 2 years. So it's extremely important that you pick up a clinical diagnosis and you refer the patients for confirmation diagnosis and potentially early treatment. Very often we see patients who are diagnosed too late. They come in extremely late with florid heart failure. Left ventricle is gone. No matter if you replace the valve, they won't pick up. So those sort of cases are quite disheartening to see, because they've been around in the community and they've seen multiple doctors and it's not been picked up. So any patient over 65 years of age who present with typical signs like shortness of breath, chest pain, have a listen to their heart. If you hear a systolic murmur over the base, conductive to the carotids, look for the other signs. If you have a suspicion of aortic stenosis, then refer the patient to a cardiologist who will most likely do an echo and some form of diagnosis is made. All the patients under the radar of the treating team will be followed up. That's the most important thing. So what we usually see, how we usually encounter patients in the tertiary case centers, most of the referrals are from GPs. So GPs are doing a great job. But often we see patients who end up in the emergency room with either a syncope or florid heart failure. And it's more common than you think. I would say in our cath lab, every week we do at least 1 or 2 patients who come into the emergency room with some form of acute symptoms. So it's not uncommon, for sure. So once a patient comes to the attention of a cardiologist, once a diagnosis is made, all cases are discussed in the heart team, which comprises an interventional cardiologist, a cardiac surgeon, nurses, nursing assistants, imaging specialists, the referring cardiologist, geriatricians. There's an overall comprehensive assessment of an individual patient before a treatment plan is made. When you make a referral, we've certainly noticed a couple of things. It's important that when a GPs make a referral, it's important to describe the symptoms. The more emphatic you are in describing your symptoms, the more likelihood the person vetting it will pay attention, because we've seen amazing descriptions where they say patients can hardly walk 25, 50 meters, NYHA3 shortness of breath. If you can classify it, it will certainly catch the eye of the person who's vetting the referral for either priority 1, priority 2, or priority 3. Describing your clinical examination, harsh ejection systolic murmur in the aortic area conducted to the carotids, words like that will be picked up by the cardiologist. If you describe your ECG as well, that all adds in. And when you always make a provisional diagnosis, a clinical provisional diagnosis of severe aortic stenosis, it is incumbent on the person who's vetting it to give it a P1 category. There's nothing wrong in being, there's absolutely no shame in making a provisional diagnosis without any sort of imaging confirmation of severe aortic stenosis. Once it's there, it's the priority goes quite high up. Doing basic bloods, BNP levels is also very useful for us when we go through the vetting process. So the more descriptive you are, and the more committed you are in making a provisional diagnosis, the higher the priority for the patient when being vetted. So what are the treatment options available for patients with severe aortic stenosis? So it's at the end of the day, it's a mechanical problem. It needs a mechanical solution. Pills are not going to help a stenotic valve. You can give pills for heart failure, hypertension, and so on and so forth, but the basic problem remains. So it's always some form of aortic valve intervention. Aortic valve replacement, one way or the other, is the most important treatment that's needed. And it's important that the valve is replaced before sufficient damage has already been done to the left ventricle and the other chambers. That's the key. If a person has normal LV function, the right heart function is completely normal, and they have an aortic valve replacement, they essentially have a normal course of life for that age. But once the patient has other valve disease like mitral regurgitation or right heart failure, even after you replace the valve, the survival is not normal. It comes to about 70% of what is usually expected from that particular course. So it's important that it just underlines the fact that these patients need to be picked up early, referred early, and treated early. Because at what stage you treat them also determines the outcome. So traditionally, for the past 40 years, there's been surgical aortic valve replacement, where the surgeon puts the patient on bypass, opens up the aorta, removes the valve, and replaces it with either a tissue valve or a mechanical valve. In patients above 60, 65 years of age, it's invariably a tissue valve. There are certainly different types of valves, stented valves, stentless valves. That's a choice that usually the surgeon makes depending on the anatomy that they encounter and other factors as well. Now, for the past 2 decades or so, there's transcatheter aortic valve replacement, where the valve is replaced not by opening up the chest, but through catheters in the groin or some of the alternate access sites. There are different types of valves, balloon expandable, self-expanding, and certain other valves in trial. This is one sort of valve that we use. It's a Sapien 3 from Edwards. It's a balloon expandable valve. This is the diagram where we inflate the balloon, the valve is mounted on it, expands, pushes the patient's valve away, the new valve inside takes over. And that's how it stays. So what's ideal for a patient? Is it surgical aortic valve replacement or transcatheter aortic valve replacement? Over the past 2 decades or so, there's been a number of trials that has looked into surgery versus transcatheter replacement of aortic valve in all risk group patients: high risk, extreme risk, intermediate risk, low risk. We're not going to go through all these trials in detail, but the long story short is in high risk patients, TAVI did better than surgery because as you can imagine, it's a percutaneous technique, and the patients recover and they don't have to go through the process of recovering from a sternotomy. So in high risk patients, TAVI is better than surgery. In intermediate risk, TAVI is equal to surgery, and in low risk patients, at least now for the longer term follow-up, TAVI is both are honestly equipoise. So based on this new data that's available, the American College of Cardiology and the American Heart Association in 2020 came out with this new flowchart, a new guideline to treat severe aortic stenosis. It's a busy slide, but what I'm going to emphasize is that if the patient is high risk for any reason, they've got severe lung disease, they've got multiple comorbidities, there's a risk assessment tool that we often use, like STS or Euroscore or things like that. And if it tells you the patient is high risk, they're automatically channeled down the TAVI pathway. Okay. Now have a closer look right at the bottom over here. I'll blow it up. That's all that we need to see. If they're not high risk, what they've suggested, this is just a suggestion from the international guidelines. Local practices and other practices might vary, but if the patients are 80 and above, the first indication is to proceed to TAVI, because all these tissue valves, they last for approximately 10 to 15 years, give or take. Some may be early, some may be later. The average life expectancy in New Zealand for males is roughly 83 to 84 years of age, and for females, about 85 to 86 years of age. So if a patient presents at 80, if you do a transfemoral TAVI, they recover faster, and in all likelihood, that valve will suffice for the rest of their lives. Okay. In patients who are less than 65, the other spectrum, the recommendation is to proceed to surgery, surgical aortic valve replacement. It may be a tissue valve, it may be a mechanical valve. That's a decision between the surgeon and the patient. If it's a mechanical valve, it lasts for a long time, but there are issues with warfarin and anticoagulation, so on and so forth. But if it's a tissue valve, if they have a surgery less than 65 years of age, a tissue valve will, like I said, last about 10 to 15 years. Some years down the line, they may need something extra done. That's what I'll come to about the lifetime management of aortic stenosis. The gray zone is the patients in between 65 to 80 years of age. And unfortunately, most of our patients fall into this particular group. So what the general recommendation is, if a patient is between 65 and 80, you can have either surgery or TAVI. But what they say is if your life expectancy is more than 10 years for a given patient, because they may have other comorbidities like lung disease or other things that might limit them. If their life expectancy is less than 10 years, the general dictum is to proceed to TAVI. If it's more than 10 years, then consider surgery. It's a general rule. So that's why guidelines are at the end of the day, they're guidelines. We can follow them. It's just general road signs to direct you along the way. Most decisions are made by the heart team for an individual patient, taking individual considerations. No two patients are the same. All right. So this is the summary of the the latest guidelines that is published by the American College of Cardiology and American Heart Association. I think 2 weeks ago, the European Society of Cardiology published their guidelines as well. And over there, they've used a cutoff of 75 years of age. If it's above 75, just proceed to TAVI. If it's less than 75, have a discussion with the patient. Do you want TAVI or surgery? And they make a general push for surgery if the patients are low risk. If they're not low risk, they tend to push towards TAVI. So as you can see, the TAVI is being performed for the younger age group as well, irrespective of risk, based upon the latest data. And it's important to plan for the life journey of the patient. And this is a discussion that is actively ongoing in the cardiology field right now. And there's a lot of discussion, pros and cons, and a lot of papers coming out right now. So I thought I'd just quickly introduce this topic so everybody's aware. The general rule is you want to minimize the number of open heart surgeries per lifetime. It's common sense. Nobody wants to have open heart surgery, right? Right. So what I'm going to do is I'm going to give you 3 examples of 3 patients who we recently saw where the lifetime management of aortic stenosis is food for thought. Right. So the first example is a 70-year-old farmer. He lives by himself. He's fiercely independent at home. He presented with progressive shortness of breath and 1 episode of syncope. No other significant comorbidities, essentially diagnosed with severe aortic stenosis. He wants something done. He wants to get back to his farm. And that's his main priority. 70 years, low risk, severe aortic stenosis. So what are the options? The guidelines, if you follow the European guidelines, the first option it says, okay, 70, he's low risk. You should go for surgery because his life expectancy says about 84, 85 years of age, right? So we need to get him across that point. So the first route he would have is surgical aortic valve replacement. Assuming the valve lasts, say, about 10 years, if the valve degenerates, he could have a TAVI valve in that surgical valve. It's called a valve-in-valve procedure. That's something that we often do. And once that's done, that should see him through the rest of his life. Hopefully, because that takes you up to about 90, 95. That should be good. Another option that you could do is, say, you could have a TAVI right now at 70 years of age. He doesn't have to go through the pain of recovering over 3 months, letting his farm out and not attending to it. Has a TAVI done, gets back to work practically after a week or so. If it sees him through the same period of time, 10 years down the line, he could also have a TAVI and TAVI once again. He could put another valve inside that. So the first route, you'd have 1 stenotomy. The second one, you'd have 0 stenotomies. It's intriguing. It's something that we need to think about because there are many aspects that determine whether you can put one valve inside another, like coronary access and technical things like that. The second one is a bit more, is a recent patient that we had. It's a 28-year-old lady. She had a prior history of rheumatic fever, some mild mitral regurgitation. Now she has severe aortic stenosis with NYHA3 dyspnea and pre-syncope. She has 1 child and would really like to complete her family. Patients with severe aortic stenosis are advised not to be pregnant because they're extremely high risk. Okay. She knows a lot about warfarin and she knows it's rat poison and she refuses to take it at present. So she does not want a metallic valve because a metallic valve is ideally what she should have and that'll see her through the rest of her life, but she doesn't want it now. And it has issues with pregnancy as well. I'm sure most of you know. So what options could we go through? She could have surgery up front with a tissue valve at 28 years of age. Assuming it takes, at this point, she has the surgery, she completes her family at 40, assuming it lasts for 12 years. Tissue valves never last for more than 10 years in young patients because the pressures are so high and the immune response is also stronger. It usually lasts, say, 5 to 7 years at most. At 40 years of age, she could have a redo surgery again with a metallic valve. And that should see her through the rest of her life. Right? Another option that we could do is, obviously, lifelong follow-up is needed. She could have a TAVI right now at 28 years of age, right? She goes on to complete her family. Assuming it takes her across, it gives her enough time to complete her family. Later on, she has a surgical valve with a metallic, she has surgery with a metallic valve. And hopefully by then she's matured and she understands that warfarin's not all that bad. And then you can see her through the rest of her life, right? So in the first option, again, she has 2 stenotomies. In the second one, you'd have 1 stenotomy. So again, it's something worth considering. The third one is probably the most controversial. 55-year-old gentleman, CEO of a company, highly driven, some hypertension, dyslipidemia, still enjoys some touch rugby things with friends, and he's not willing to take warfarin. He doesn't want a metallic valve. He presents with NYH with 3 shortness of breath and no surprises. He's got severe aortic stenosis. Right? What do you do? One option, he has surgery, surgical aortic valve replacement with a tissue valve. Let's say it takes him across for 15 years. At 70 years of age, he has a redo surgery once again because he's expected to live till 85. And 85 years of age, if he makes it, if that valve also degenerates, you could have a TAVI valve and valve. Right? You could put a TAVI inside his second valve. The second option is he has surgery at 55 years of age. When he's 70, he can have a TAVI valve in that first surgical valve. And when he gets to about 80, 85, you can have a TAVI in the TAVI valve as well. All right. The third option, he's 55. He wants to get back to work as soon as possible, highly driven, gets a TAVI up front at 55 years of age. It sees him through till he's 70 when he's retired, but still fit enough to have surgery. He has surgery done at that time. And at 80, 85, and if he comes back, you could have a TAVI valve and valve. Right? The fourth option is probably the least likely. He has a TAVI up front that sees him through. He has a TAVI valve and valve again. And then later at 80, 85, he has a valve and valve and valve. But those are the technical possibility of that happening is low because of access to coronaries and so on. So many issues are there. So the first option, you have 2 stenotomies, second option 1, third option 1, and the fourth none. So it's really about planning for the lifetime of a particular patient, depending on what they want, what they expect, and what their general expectations are, and depending on the anatomy as well. Right? So coming back to our initial questions, the prevalence of aortic stenosis in people over 75, it's roughly 12.5%, 1 in 8. Surprising people said 1 in 4, which would be pretty optimistic. And sure. Which of the following is worst prognosis? Symptomatic severe AS, 5-year survival is just 3%. What characteristic of the aortic stenosis murmur helps determine the clinical severity? It's none of the above. It's the delayed peaking of the murmur that tells you about the severity. And which of the following regarding TAVI is correct? It may be considered for patients with severe aortic stenosis and bicuspid valves. All trials that have been performed so far are for tri-leaflet valves. There have been no randomized trials for bicuspid valves, though it is done. With high-risk patients, we can do it. TAVI is not just reserved for elderly or high-risk patients. It's now coming into the low-risk group as well. The stroke risk is not higher than surgery. It's more or less the same or slightly less in the low-risk group. And any prosthetic material you have in the heart, you need infective endocarditis prophylaxis. It's not exclusive of any particular procedure. So, long story short, severe aortic stenosis is extremely prevalent. 12.5% have it, above 75 years of age have it. It's important to diagnose it early because 50% of patients will be dead within 2 years of diagnosis, of symptom onset. So it's important that you listen to the patient, have a clinical examination, formulate an early diagnosis, and refer the patient before the ventricle gets impaired and things are too late. All right. That was aortic stenosis in brief. Do you guys have any questions?
Of course, we've got questions. Isn't that how it goes, eh? Thank you very much. So before we move to the questions, that was fantastic. You can certainly see your passion for what you do, and you've obviously got a lot of life in you yet to drive this further along the path. And I'm sure you'll be doing some presentations when you do have your conference and updates next year.
Absolutely.
And when you do your echo training. So that'll be very exciting.
Yep.
We look forward to seeing the adverts for that.
Perfect.
And so someone's asked here, could you please let us know whether CT coronary angiogram scans show the aortic stenosis or not?
CT scan is a static image. You can have 3D CTs as well, but you can see calcium deposits in the aortic valve per se. Can you diagnose the severity of aortic stenosis just from the CT scans? Maybe. There's a scoring system called an aortic valve calcium score. They estimate the Hounsfield unit thickness of the leaflet calcium. If it's above 2,000 units in men or 1,200 units in women, it usually suggests the patient has got severe aortic stenosis. But is it the first modality to diagnose severe aortic stenosis? No, it's not. So you can guesstimate the severity of aortic stenosis from the calcium score involving the valve leaflets. Right.
Thank you. Is this common in renal failure?
Yes, it is. It is certainly common in renal failure. In fact, it's just last week, there was a paper out in JACC Intervention regarding severe aortic stenosis in patients with chronic renal failure. So in patients with CKD, you know that their calcium and phosphate metabolism is off. They can often have secondary or even tertiary hyperparathyroidism, and you can have calcific deposits all over the body, including the aortic valve. So it's roughly estimated about 5 to 10% of patients with CKD have some form of aortic stenosis. Doesn't have to be severe, but certainly it is common in patients with CKD.
Okay. How long are the waiting lists for surgery in public?
Oh, that's a good question. That is a loaded question. I can certainly speak from the percutaneous point of view. The surgical side the surgery has got a slightly longer waiting list but from the percutaneous aspect here at Waikato, once the patient has been seen and assessed by the heart team, the patient would have the procedure done within 4 to 5 weeks at Waikato.
Thank you. Someone's asking, what is the youngest age that you've seen someone with the aortic stenosis?
I've seen a neonate with congenital aortic stenosis. Maybe that child was hardly 2 or 3 months. But that's more on the pediatric side of things. It's not a disease of you can say it's a disease of the elderly, but it comes in all shapes and sizes. The congenital forms, like the unicuspid valves, they come in the smaller age groups. The bicuspids in the 50s and 60s. It's seen in children also. And the unicuspid valves and the congenital aortic valves, they're amenable to balloon dilatation. They get across for a longer period of time with just balloon procedures. You don't have to replace the valve per se. It's quite different from the calcific valves that we see. All
right. So in terms of that, how significant is aortic sclerosis? Should we be following them for progression to aortic stenosis or wait until they are symptomatic?
That's a great question. Aortic sclerosis is just deposits of initial atherosclerotic plaques and calcific deposits on the valve. And there have been multiple studies that have been done, and it's estimated about 20 to 30% of patients with aortic stenosis, when they're followed up over 8 years, go on to develop severe aortic stenosis. So the rough figure is about 20 to 30% of patients with aortic sclerosis will develop some form of stenosis within the next 8 years. So it is important to follow them up. It doesn't have to be on a yearly basis. So say about every 3 years, have a follow-up clinical examination, and if need be, an echo.
Okay. Can we briefly discuss which groups of cardiac medications should be avoided in aortic stenosis?
That's a great question. That's a great question. So aortic stenosis produces a fixed obstruction. In the general principle is you need to avoid vasodilators, because when you dilate out the arterial system, the heart cannot fill the vasculature with enough blood to maintain an adequate blood pressure. So avoid any form of vasodilatation. Avoid GTN sprays. Avoid nitrates. You need to avoid ACE inhibitors or any sort of calcium channel blockers if their blood pressure permits. If a patient has hypertension, it's common. The patients have systemic hypertension, you treat the hypertension as per normal protocol, but be gentle with their medications. That's the general rule. Be cautious regarding if patients have issues with impotence and things like that, you have to avoid sildenafil and things like that. They may not bring it out. It's some patients are very embarrassed to bring it out, but it's important that you ask them and ask them if they're using it. And if need be, that needs to be stopped till the valve is sorted.
Thank you. And so someone's saying here, as a registered nurse, we don't diagnose, but as a differential diagnosis, what do I tell a GP for it to be considered, especially working in aged care?
That's a really good question. Any form of so when you hear a murmur, an ejection systolic murmur, it can be multiple things. It can be aortic stenosis, or accelerated flow across the left ventricular outflow tract. Another diagnosis is hypertrophic cardiomyopathy, where the obstruction is not at the valve level, but below the valve level. Or it could be accelerated flow across the pulmonary artery because of other rare causes like pulmonary stenosis or pulmonary artery dilatation. Those are all rare causes. The common things are either aortic stenosis, or aortic sclerosis, or even hypertrophic cardiomyopathy. Those are the usual things that you usually think of when you think of an ejection systolic murmur at the base of the heart.
Thank you. What's the difference in the recovery time between a TAVI and between the surgery?
So a transfemoral TAVI, once the patient has it done, we keep the patients overnight, do an ultrasound scan. If everything's fine, they're sent home. Within a week, they're back to doing everything that they usually do. In fact, we make them walk 4 hours after the procedure. So 4 hours after the procedure, they're up and about and walking around. We just keep them an extra day just to make sure everything is fine. But there are centers around the world where it's done as a day procedure. They have it done in the morning, they leave at night. We are not there as yet, but it's work in progress. Essentially, the patients are back to their normal selves the next day itself. We just tell them we tell them take it easy the first week or so. And we tell them to avoid driving for 3 to 4 weeks, because by law, we don't make the rules. By law, they're asked to stop driving for 3 to 4 weeks. Surgery, they take time to recover from the sternotomy and the stresses of going through a major procedure. Usually, if the patients are young and fit, it takes them about 3 months to get back into track and feel the benefits of the valve being replaced. If it's older group, it takes about 6 months for them to feel the benefits of having the valve replaced. So 3 to 6 months for surgery and almost practically the next day for TAVI.
Yeah, quite a big difference, eh? Is TAVI available in private, or can patients have an echo in private to confirm the diagnosis?
It is done in private. There are quite a few centers who offer the procedure in private. And they can have the entire workup that they have in public in the private sector, either through insurance or some patients often pay for it.
Okay, what are the current recommendations for antithrombotic therapy following prosthetic valves?
Oh, that's a great question. As of now, there have been multiple. Previously, we used to put the patients on dual antiplatelet, 2 antiplatelet like aspirin, clopidogrel, and things like that. But there is good data now to show that all patients need is just a baby aspirin. That's all they need. If they are on anticoagulation for something else, say atrial fibrillation or anything, then we just leave them on their NOAC or warfarin. If they're already on dabigatran or rivaroxaban or edoxaban or whatever is it they're taking, we leave it at that. We don't change it. They don't need an aspirin in addition to it. Some patients have stents as well as a TAVI valve that's put in. In those cases, they might need they might need dual antiplatelets to cover for the stents, not for the valve per se. But as far as the valve is concerned, it's just aspirin.
Thank you. And what is generally the cause of sudden death with these patients? Is it sudden cardiac arrest, and why?
So that's a really good question. So aortic stenosis has got a long latent period. They may be apparently asymptomatic, but even in asymptomatic patients, the risk of sudden cardiac death is 1%. The exact cause is not known, but it's believed to be a ventricular arrhythmia, arrhythmic death, like VT or ventricular fibrillation. But once patients become symptomatic in the downhill stage of their course, the risk of sudden cardiac death usually jumps to about 2 to 3%. And it either from sudden heart failure and pulmonary edema, or it's usually an arrhythmic death, a ventricular arrhythmia that usually causes sudden cardiac death. What happens is if a patient has syncope, the output transiently decreases. There's global hypoperfusion of the heart as well, that triggers global ischemia and arrhythmias. That's the believed dictum, believed causation for sudden cardiac death. But the exact cause as to why it really happens for one particular patient is not really known.
Thank you. And then after surgical intervention, 15 years on, how would a patient present if there is failure or need for replacement?
Oh, that's a really good question as well. Patients can have the prosthetic valves, the common prosthetic valves that are put in, they become thick, calcific, and they become stenotic as well. So essentially, they represent with a bioprosthetic aortic valve stenosis. So it's essentially the same symptoms. There are other valves called stentless valves. Where I showed a brief picture of that earlier on. They usually leak, and patients present with features of aortic regurgitation. Less common, but more often they present with aortic stenosis once again. Same group of symptoms: angina, syncope, shortness of breath, maybe sudden cardiac death as well.
And then just to go over, you kind of went through this with your scenarios, but just to clarify for someone here, what would you recommend for an active 70 to 75-year-old with no other major comorbidities?
That's a discussion that we'd have with the patient.
Yeah.
What his expectations are. If he has no other comorbidities, if he's relatively young, low risk, we'd obviously look at the anatomy as well for future intervention. If he has a TAVI now, that'll see him, say, 10, 12 years down the line, he can have a TAVI again. But on the other hand, he says that I'm fit now, I'd rather have a surgery right now. And that works me up towards a TAVI later on. It really is a discussion that we have with the patient.
Look at you. You just race through them like a horse in a horse race. Fantastic.
Take time to answer questions. Right? That's more interesting, and you also learn quite a bit with the questions that come in.
Yeah, it just sort of covers off those edges, doesn't it? But no, thank you so much for sharing your knowledge and your passion with us this evening.